Can you hear me okay? Okay.
Oh, yes. I just started the recording again. Thank you so much. Really appreciate being here.
Great. So I want to talk about symptom management in general and then dive into nausea a little bit more to cap the day with some unpleasantries. So where is my here? And the objectives are really that you walk away kind of having a sense how to structure an encounter or visit that is built around symptom management. And then with nausea and vomiting in specific, like to understand how it happens and what tools you have available to treat it. I don't know how all of you are feeling. When I started fellowship, I was kind of preparing to be this, like, have the bunny I can pull out of my head at the end of the year and be ready to kind of magically make symptoms disappear. It's not quite like that. It's a little more confusing and complex, but in the course of this year, you'll start getting a really good sense of orientation within all the symptom interactions and medications and non-pharmacological treatments and how they influence each other. And it's actually much more fun than just pulling a bunny. So this is how I think about visits. And so the first step is on the left-hand side. So first you would just collect what people need to address. And so you keep asking what are things that you've struggled with? What makes your days difficult? What symptoms do you have? Look through the chart if anything is in there to also anticipate issues people might be facing. And then the next step is to create an agenda and really set priorities. And it's absolutely okay if things get delayed for the next encounter or the next visit, or a different team that's better set up to address certain aspects. And then you start listening. So you're the left-hand side, you're the one asking a few questions and then really listening to get a good story and a good sense of what's happening with the patient in front of you. And then the final step is really kind of thinking it through, reason it through, and start mapping out what are the steps I'm going to take, what issues do I anticipate, and what other measures could I take if my first line treatment doesn't work. And especially the first step, kind of keep asking. And I'm really invested in asking patients to the point of sometimes making them a little uncomfortable and lost, because, and it's one thing is from your own experience, you probably know with doctor's appointments or at the car shop or whatever, that you walk away and then you think, oh, I didn't ask this, right? So often people don't lead with what's very important to them. And then this is a study which is a little bit older by now. It's from, I think, 2005 or 6. And people picked 200 palliative care patients and just had a normal visit, right? Where you elicit kind of what's going on. They volunteer some symptoms. And then afterwards, they gave them a questionnaire with 48 symptoms, and people could check off if it's not an issue or if it's, mild, moderate, severe, and how distressing it is. So between the 200 patients, they came up with well over 2,000 symptoms that people checked off as having those symptoms, and only about 10% were volunteered initially without that questionnaire. And this slide is what I find much more impressive. So the yellow ones are the symptoms that people volunteered. So about a fifth of the distressing symptoms and a third of the severe symptoms was volunteered, and all the rest people needed the prompt from the questionnaire. And so it's worth asking if you suspect a symptom, if you see something in another specialist's note, if there's a symptom that typically happens with certain illnesses or disease processes, do ask, right? Has this been an issue? And there's a few that are more likely for patients to not share with you. So pain is pretty reliably. People share that they have pain, nausea, and then fatigue, sleeping problems, appetite issues. These symptoms that people feel are like, well, what are you going to do about it? Are the ones that people tend to not volunteer. But in general, if you suspect something, better ask. And then you make your priorities, and that's really kind of being transparent, right? So tell the patient, okay, we have 4 things that really need attention. those two, I think, can wait till the next visit. Let's focus on these two first and see how far we get with it. And then, the third step is where you start understanding the patient's story. And, so we see the patient as a patient, but each symptom doesn't only affect their physical experience, but it also affects kind of what part of their role can they fulfill. And that can be, parenting or family roles. It can be their jobs, it can be their hobbies, it can be the things that they need to kind of have a sense of themselves. So the social aspect. Unfortunately, financial problems often play a big role and do influence how people share their experience with us and how people share what's going on with them. Sometimes certain symptoms influence people's spiritual well-being and vice versa. So to get a sense of that realm of them, and you'll learn more about that. I can imagine that you have lectures coming up on spiritual health and spiritual assessment. And then also psychologically, which is, I think, kind of becoming more and more obvious in the healthcare system, that each symptom also affects how patients feel overall. How concerned they are about a symptom can affect how much distress they experience with a symptom. And so these are really important aspects to understand, like the social, financial, spiritual, and psychological context of a symptom. And actually, to go back to this slide is one thing that is also really important to be aware of is that how severe a symptom is. So like mild, moderate, severe does not necessarily connect to how much distress someone has around it, right? So a relatively mild symptom can become very distressing if patients, for example, had a bad experience with that in the past, or if they worry it means something terrible is happening with their disease, or if it means they can't tolerate part of the treatment. So they kind of, as you ask questions, also figure out how much people are bothered by certain symptoms, because on the flip side, people can have pretty bad symptoms and somehow don't think it's important to address it and sit relatively well with that and don't have a lot of distress around very notable symptoms. And in this whole world of distress and severity, you will come across scales, and they are a really great tool to keep track of the severity. They make research meaningful and are really essential for that world. As you interact with the scales, there's a bunch of scales out there. Some you'll come across a lot and some are a little more exotic. Be aware of what they measure, right? Do they measure the patient's experience, the caregiver's experience, the clinician's experience? Do they ask about distress? Do they ask about severity? Do they ask about yes, no? Do you have the symptom? Also, what is clinically meaningful? And we know this from other parts, right? So if you have a scale from 0 to 10, where does it really make a difference in a patient's life? Like how much of a gap does there have to be for a medication to change how a patient experiences it? And you'll see research being done which shows a statistically significant difference, which clinically is not meaningful. And many of the scales by now do have data behind it where we start understanding what is like that meaningful gap, right? ESAS, the Edmonton Symptom Assessment Scale, is one that I find really helpful and also helps in the clinical world and is very applicable. It asks about 8 common symptoms. It gives you the opportunity to add a symptom. So if a patient struggles with something that's not part of that given list, you can add that in and track that. And I love that it also asks about overall well-being, because that doesn't necessarily correlate. 0 to 10 scale, which is for us working in medicine, a very intuitive thing. And as you know, for patients, sometimes a little hard to navigate. And I'm sure you've had your 15 out of 10 pain reports, which, just shows that our way of thinking doesn't necessarily translate into real life all the time. For the talk today, I'm not going to delve deeper into scales. If you are somewhere where research is actively being done, you'll probably learn a lot about them. And otherwise, just be aware of these kind of aspects of, like, if someone tells you, oh, it made this much different, understand what that means. And now we get to the final step of the encounter, right? So you understand what the patient is struggling with, the patient and you have created an agenda and prioritized. You've heard the story, you kind of get a sense of what their experience looks like, what they struggle with, and how much it affects what aspect of their life. And now it's time for your clinician brain to kick in. And in hospice and palliative medicine, we do a lot of management reasoning. So kind of thinking through how we want to respond to a situation. In other training, you probably have spent more time about learning about diagnostic reasoning, which is like kind of what is going on, what is on your differential. And this is a slightly different way of thinking about reasoning and clinical problems, because there's usually more than one very reasonable option, right? So think about what you want to do, think about what else you could have done, and what are the things that help you decide for one pathway over another. And then also, especially if you work in clinic and outpatient settings where you have a bigger gap between your visits, think about what issues might come up, how might the patient notice it's working or not working, and what would be your next line and next step. Anyone covering you while you're out or on call or not at the site is going to be immensely grateful if you put that in your note and say, you know, if the patient doesn't have relief, my next step would be to increase the dose or try a different medication, and kind of be aware of there's a future for all of this. One thing which I find, like, so, you know, with diagnostic reasoning, there's a presumed truth, right? So we assume if you make a diagnosis, there is some true answer. With management reasoning, it's not like that. So people will have different approaches. And that's what I love about our field is like, and especially in fellowship, you get to work with all these different people who do things differently and like enjoy the breadth, even though sometimes it can feel a little bit overwhelming that there's like 3-4 correct answers. And sometimes you might come across staff who's not really leaning into that and think they have the one truth. In general, it's not like that. There are still wrong answers though. So that is also a thing. And, you know, so coming into the fellowship, as physicians, we are very much, and also what we learned today, we are very much focused on using medications. And that's really our role on the team. Be aware that there's a lot of non-pharmacological treatments that actually are starting to have increasing data behind them. And things that I implement a lot in my clinic work is, so our social workers do a lot of mind-body techniques, and, you know, find out in your kind of system and on your team what training people have. And sometimes it's really simple stuff, you know, like mindfulness practices or encouraging patients to continue things they're already doing and maybe label them different than, and don't see them as a tool to treat a symptom. But when you hear them say, well, I feel better when I do X, Y, Z, and it can be, you know, like watching game shows on TV, right? So it's something that gives you a good space. Physical therapy and occupational therapy can be immensely helpful in symptom management. Counseling, cognitive behavioral therapy has had good results in some studies for certain symptoms. And then we have the whole integrative world, and aromatherapy and acupuncture tend to be the more accessible ones, but maybe you have some other great opportunities where you work. And I think it's important for us to remember that those things are there and can be really helpful. And in general, symptom management is the most successful if you have a multimodal approach. And a lot of that is really like in pain management, right? So we don't want to just rely on opioids, but want to nest that in an approach that takes advantage of everything we have available. Another thing that's like pain management is when you do use medications, you know, also in the talk about opioids, you know, we have these opportunities of using long acting as a foundation, and then the PRN medications, the shorter acting for breakthrough. And in other symptoms, often we don't have these clear groups of medications, but I think that general mindset can be immensely helpful to say, oh, maybe I schedule something that they have like 24/7 coverage for this symptom because they struggle with it 24/7. And maybe, definitely talk to your patient about that option. And then same like with the pain medication, follow up, check in with them, and then most importantly, deprescribe once the symptom improves, once you've identified that the medication isn't helping, or you found some other means of supporting them, right? So have deprescribing as a fixed part and step of your medication management approach. Another piece in non-pain symptom management that you'll notice is that generally our data tends to be not phenomenally solid, right? So we have a lot of thoughts and ideas and hypothetical tools that we feel should work and have been shown to work in trials that might not be very large or have a very diverse patient population. So it's not doesn't immediately translate into the situation you find yourself in. Think of N of 1 trials and kind of guide your patients through it to say, okay, we'll try this medication. We need to give it this much time and we need to get to this dose to really know if it's working or not. And then we can, if, sometimes people are very certain and then it's okay to continue it. Sometimes people are not quite certain. And then you can say, well, let's take a break from the medication and see if your symptom comes back or not, or gets worse or not. And to really have this mindset of trying things out and being very explicit to the patient also, saying, including like a preview, like if this one doesn't work, I do have other tools that we can try too, so that they don't have so much pressure on this kind of trial period. You will read about symptom clusters, which is and intuitively, probably before you went to medical school, that would have made even more sense. But even now, a lot of symptoms come hand in hand and influence each other. So the obvious ones are, for example, appetite, nausea, energy. How much energy do you have to sit through a meal? How is your appetite? And if you're nauseous on top, it doesn't work so well. A dry mouth doesn't help. So those are very obvious symptom clusters. And then there are the more kind of remotely connected ones, which are also, really connected in a way beyond just occurring together. And in research, there's a lot of really interesting research around how do clusters occur, how do they influence overall outcomes of well-being and function. And again, I don't do research, so I'm not directly involved with that. I find it a really fascinating concept. And it'll help you also to have that mindset in your day-to-day clinical work, because often when you talk to patients and check in with them, do you think if we get this one symptom better, what else do you think will get better? Then they often have a really good sense of how things are connected and how you can help in a much more efficient way than just checking each box separately and never connecting the dots. To my knowledge, there hasn't been much research in kind of that direct one-on-one patient encounter implementation of symptom clusters. And I think it's a little bit of a stretch of the term, but it's been really helpful for me as I take care of patients. So this is the structure. Again, keep asking, check in with people, don't be shy to, circle back to collecting, making a list. And then prioritize, find a way to remind yourself if you postpone something, right? So you don't just not do it and fall through the cracks, but that you have it on your list for the next visit to consider again. Really listen and hear the story around the symptoms so that you can get a sense, beyond just like, where is your, with pain, we all have this like OPQRST, I think it is, model, and also use it for other symptoms and go beyond just the obvious physical bits. And then the final step, use your management reasoning and help your future self or your covering colleagues by thinking of the next steps as well. In your fellowship, you'll spend a lot of time on those last two steps, and that's really where the fun happens and where you have these good patient encounters and really grow into being an expert. Symptoms can help with prognosis. And it's, it came up in the last talk about some symptoms tell us that someone is very close to the end of their lives. And then also in cancer, especially, there's been a good amount of data around certain symptom, and again, symptom clusters are often mentioned in this context. If someone starts having a lot of accelerated symptoms, then often it can mean that prognosis is limited. This is always something you need to take in context, right? So don't just look, you read some headline of a study and don't just run with that. Always look at the big picture and what else is going on, and always also look for other etiologies of symptoms that might be contributing, right, and kind of causing some confusions. But I think start watching out how symptoms behave and how your patients progress through their disease trajectory is, and you'll notice these patterns of kind of lulls, for the lack of a better word, where people stabilize and then things speed up again, and you'll notice these patterns and trust your instincts around that. So, and why do we care about treating symptoms? And so one is, of course, that's what we do because we're in hospice and palliative medicine, but it has an impact on the quality of life, not only of your patient, but also their caregivers. And depending on what disease people are dealing with, there's actually the impact a symptom can have on the caregiver can be as much, if not more, than for the patient themselves. So really pay attention to that aspect of your work. Good symptom control can improve treatment adherence. And sometimes it's really obvious, they take the medications and the medications actually stay in them, right? And don't get thrown up again. And sometimes it's just having the bandwidth to, be awake and be at the appointments and kind of sit through a whole infusion session. Symptom management might improve survival. The data is not super reliable on that. What we, I think, great if it does. And even if it only, quote unquote, improves quality of life, that's worth it too. So before I transition to nausea, any questions so far?
I think what you mentioned about digging a little more is very important, because as you said, a lot of times patients don't really volunteer stuff unless you ask them. And it can vary a lot from patient to patient, especially some of the very stoic patients. Sometimes you have to ask a couple times before they admit it. And sometimes you really have to even develop a rapport with them and see them a couple times before they'll tell you anything about their symptoms.
Thanks. Yeah, that's absolutely true. And I always love when spouses come along, because then you often see head shakes and head nodding that's not congruent with what the patient tells you. And that's been a really helpful source of information.
Oftentimes it's the spouse that gives you the real history.
True.
Oh, and also if a farmer says that it's painful, then it's a bad situation.
Yes. Looking for my control here. And you can also put comments and questions in the chat, and I hope someone will help me later sort through them where my thing started. So nausea is the symptom I'm going to focus on today. And I'll start with a case. So a 48-year-old woman with cholangiocarcinoma, she's on palliative chemoradiation, came into the hospital yesterday for a pain crisis. Today, you see her, she has more nausea, she vomited twice. She has on the Ansatron 4 milligrams Q6 PRN available. Just think about it in your own mind for a minute. What do you think is causing her nausea, or could be causing her nausea? And kind of based on that, actually you can unmute or put it in the chat, or we can just give everybody some time. Like what are the things you want to know, and what do you think you do for her? And if anybody wants to speak up, please do. Great. So yeah, what worked before, if she had nausea before, like, does she have constipation, any medication changes, getting more information on the pain, was the chemo involved? So great question. So you get more of a history, right? And I think you've touched on almost everything that we typically kind of start with, right? So and it's how to say, it's surprisingly stable how people respond to certain antiemetics. So finding out what has worked in the past for a similar situation can be really helpful. Bowel movements are extremely important to learn about, and constipation can really, like, if not cause, then definitely worsen nausea. And then medication changes, true, some medications don't get tolerated very well, and the famous one is opioids, which we'll talk about in a minute. And then did the chemo play into this, right? So she's getting chemo and radiation, and both of those treatments can cause nausea, like independently from other causes. And then what do you think you would like to do for her? And, you know, as you come up with this list, I'm just kind of doing reflective listening, because a lot of times nausea is multifactorial, right? So you will have occasional patients where you really nail it down, like, this is causing the nausea, and if I like get this trigger away, they're fine again. Usually the only times that happens is like chemotherapy, right? And nothing else is going on. In general, people have multiple factors that probably are playing into the nausea, or at least not helping and worth treating. So what's your suggestion? What would you like to do? So far, all she has is the Zofran. So, oh, great, thank you. Right, so manage contributing factors, rule out bowel obstruction, so some sort of imaging for that. Look for calcium, which is a really good point. So some metabolic derangements can cause or worsen nausea. So let's say she has a lot of stool in her bowels, but no frank obstruction. She had a little bit of nausea before coming into the hospital. Zofran tended to work well enough, not like, you know, good enough. She hasn't tried anything else for nausea in the past. This is the first time she's had IV opioids. At home, she occasionally took, you know, a Percocet, but rarely, and can't remember getting nauseous with that. I think I have this actually on the next slide. Yes. Also, sorry. And then, so what you do for her, classic, is people like tend to add compazine if someone is already on Zofran. And with 4 milligrams, you can increase the dose to 8 milligrams if you want to. It can go all the way to 16, and people seem to still get some benefit, but from 4 to 8, you definitely get a clinically noticeable improved control. So the compazine seemed to help. Zofran, she's still not sure. She stopped vomiting, but doesn't feel great. So what you do now, what people already said, so you really aggressively treat the constipation that she has. And what else can you think of doing with the medications? So we seem to be onto something with the, we seem to be onto something with the compazine. And so olanzapine is the new darling of antiemetics in palliative care. And so you can swap out the olanzapine for the compensine. You can schedule something. You can explore other additional, pathways, and that's what we're going to talk about a little bit. Kind of how do you conceptualize how nausea happens, and how does that help you in choosing treatment? And in the current environment, and I'm pretty sure it'll change in the next couple of years because it always does. But if you have someone with nausea and you start them on olanzapine, someone's going to get happy on the team, right? So, and it's been really like the studies are exceptionally good, and it seems to help a lot for people. So if you walk out with one medication in your toolbox today, then try that to be olanzapine. A quick note on nausea and vomiting, and she was a great example because you have these people who come in with both, and then one stop, like the vomiting stops, and it feels like a success, but the patient is still really miserable. And so nausea and vomiting, they have been lumped together. I will continue to lump them together for the rest of the talk. Also be aware they are really distinct entities, and they happen in a different way. The pharmacology is separate. The pathophysiology is most certainly separate, and the experience for a patient is very distinct, right? So if someone, quote unquote, only vomits occasionally, it's a very different experience, and it's not great, but it's a very different experience than someone who's constantly nauseous and doesn't vomit or vomits occasionally also. But people don't, like, as much as we would like to just put it in one bucket and treat it as one, people don't experience it like that. And if someone stops vomiting, it doesn't mean they're overall feeling better, because nausea can be really miserable. Oh, yes. So thank you. So if a lot of the medications in non-pain symptom management are medications that are traditionally used for other things, right? And olanzapine is a big one. Like, make sure you tell them, I'm giving you this for nausea. It's also used as an antipsychotic, so that they are prepared for Dr. Google. And you'll know it also from neuropathic pain medications. If you use buprenorphine, especially in a Suboxone formulary for pain, talk to your patients about it, because they will get comments about that. And then, so when you look at vomiting, it's a really well-adapted response in the end, right? It's a very complex motor function that protects your body from things that shouldn't be in your body, right? And there's good animal models, so we can do very basic research around it. And nausea is different. It's higher up. It's more influenced by emotions. Also, vomiting can be too. It's not really adaptive, right? Like, yeah, it's some sort of learning, but it's not a very reliable tool. It ends up being more difficult to treat. It's something that really can decrease quality of life substantially. And we don't have an animal model because you don't know if a mouse is nauseous or not. So keep that in mind as you treat patients and interact with patients, and feel like so happy that they stop vomiting. They might not, and that's okay. We can have separate experiences. A few specific kind of versions of the symptom is very obvious: the chemotherapy-induced nausea and vomiting, which comes in two pathways. So the acute one in the first 24 hours, and then the delayed, which usually shows up after 2-3 days. Some people get it later than that. And those are separate agents and pathways that trigger those. And so, which also explains like the different medications that are being used. The chemotherapy-induced nausea and vomiting goes through the chemoreceptor trigger zone, which I'll talk about in a minute. And you'll understand why I put that in there in a minute. Again, it's acute versus delayed. The prevention is, at least in our team, and when I talk to other people around the country, usually the prevention is done by the oncology teams, right? So we in palliative care don't have a lot of direct involvement in setting up those medications. Look at the ASCO guidelines. It's not rocket science, right? So look at the guidelines. If you Google ASCO guidelines for chemotherapy-induced nausea and vomiting, they have a nice PDF where they just spell it out for adult and pediatric patients. And it's just so you have a sense of how they do things. And because you get the patients and then expected to treat the breakthrough nausea, which in moderate to high, highly emetogenic chemotherapy, still around 40%, even with the prevention we have available now, do experience some breakthrough nausea. And I kind of skipped the middle part. So chemotherapy agents are grouped. So some have from the minimally emetogenic to the highly emetogenic groups. And I mean, the moderate ones are still between 30 and 90% of patients who get this experience some nausea. And I mean, it's just like a really reliable symptom that you'll see all the time. And so if people get combination, you just count whatever is the highest emetogenicity of, and it doesn't average out or something, which, you know. The other kind of frequently discussed nausea is the opioid-induced nausea, which is something that I think is over-feared. Like, so it actually doesn't, it comes up a lot usually when people have rapid increases in the serum levels. So, you know, if you give it IV, if you have the opportunity to give sub-Q instead of IV, if you can't do oral, that might mediate it a little bit. But talk to your patients about this, right? So you can give them antiemetics around that time to help them kind of get to their level, get to a stable and steady state. And then almost always the nausea improves once they have stable doses. It's really rare that someone remains nauseous on opioids. And then often a rotation helps with that too, because it's not a class effect. The mechanism is not entirely clear, probably also has something to do with the chemoreceptor trigger zone. We know very well that opioids change the motility of the GI tract on multiple levels. There might be a vestibular component. In general, like we use the dopamine and serotonin corner of treatments for this, and really think about it. If someone has worries around, I got nauseous with opioids in the past, you know, say, you know, we'll give you some medications. Once the doses are steady, you will very likely lose the nausea again. I used to say, let's give you a dose and see how you tolerate it. And I've learned just pre-medicate, it's fine. They get an extra dose that they might not have needed, it's okay. So how does nausea happen? And like nausea and vomiting. So these are the centers that are involved. So to get to the right-hand side of the slide with nausea and vomiting, it gets mediated through the vomiting center. We'll get to the yellow line or green line in a minute. And the vomiting center is really kind of a, there's a nice word for it, not pacemaker, but like a motor coordination pattern generator is the word, where our body is able to vomit out things that it needs to get rid of in a way that still is relatively safe for the rest of the system. And that can get triggered by the GI tract itself. And that's one of the more obvious ones. The vestibular system, we all are, probably most of us unfortunately have had personal experience with that. The cortex is, so one is the more mechanical piece. So if you have like intracranial pressure, then, you know, that can trigger the vomiting center. And then also the cortex can have like emotional, learned, or otherwise kind of, the more emotional influence on the vomiting center. And then the chemoreceptor trigger zone is a really interesting area at the bottom of the fourth ventricle where the blood-brain barrier is thinner. So it's kind of the brain holding out a feeler to see on what's happening in the bloodstream. And if there's something funky going on there, then that can trigger the vomiting center and cause nausea and vomiting. And the cortex, the emotional piece is like the green line. So that often kind of bypasses everything else and just gets you nauseous without much rhyme or reason, ironically. And so these are the kind of influences that tend to, you know, kind of trigger these pathways. And in the GI tract, it's the most variable, right? So like toxins can work on multiple levels, and then the stretch receptors in the GI tract are a very direct way. And each of these areas has specific receptors that are active. And so like, you know, this will come up repeatedly in your fellowship, but I think the one thing I want you to notice is that there's a lot of repetition here, right? So when you look, the dopamine is in multiple locations, serotonin is in a lot of locations, and then some are more specific, like the histamine in the vestibular system, which is like why we don't do much antihistamines for nausea in our world, because that's usually not one of the major pathways. The ghrelin in the GI system is something where I hope we get a tool sooner or later to actually use that pathway for treatment reasons. But the other ones are really the ones that you'll come across a lot. The dopamine, serotonin, and NK1 are the ones we'll talk about the most. So you like dopamine mediated medications to kind of connect this last graphic to what you actually use in clinical work. Olanzapine and compazine are the big ones here. The serotonin antagonist is ondansetron is the one you'll come across the most, and we'll talk a little bit more about the other ones. NK1 aprepitant is really mostly going to be used by oncology in the pre-medications for the chemotherapy, but then you'll see the patients who received it and see the results. And then the acetylcholine and histamine ones are the more, like, you know, the kind of second line, third line tools we use. If you flip, so this was kind of which receptor is pertinent for which medications. And, you know, as you saw on the previous graph, the receptors are not a clean-cut correlation, right? So they pop up in multiple spots, and then the same thing happens the other way around. So most of the medications affect more than one receptor. Don't memorize this, please. This is only to show you that sometimes things work that you didn't really expect to work, and that's okay, right? So none of this is clean-cut, but I do want you to, in your mind, kind of have these connections as a scheme to work from. And also when you kind of add medications, that you try to move into a different group rather than doubling up within one receptor pathway, even though they have some, you know, additional agencies. And so this is what this is the world we work in with our medication treatment. There is more and more talk about how the GI regulation happens like in a more direct fashion, and it's also bidirectional, right? So the brain and central system influences the GI tract and vice versa. And then there's the autonomous and the enteric nervous system, which are involved, which we're learning more about. And the endocrine cells we're learning more about. So I could imagine that eventually we'll have additional tools based on these relationships, but right now we don't really. So keep an eye open and cross your fingers. So now I'm going to talk more about the medications and check the, oh, thank you. Well, I'll get to that. Short answer is yes, and I wish it wasn't, but I'll get to it. So the biggies are the serotonin antagonists, and I think wherever you've worked in medicine, probably that's been like the thing, like to get someone on Zofran. And it's the first generation medications are the ones we use kind of in our practice, mostly Zofran really. The other two rarely come up. Palonosetron is nice because it's IV, but it has a longer half-life. So that also, again, oncology is usually the team using those, and they also kind of time it specifically to cover the time after the chemotherapy when people have nausea. The data for ondansetron is really good in our world, chemotherapy-induced nausea and vomiting, radiation-induced nausea and vomiting. It's really not great for kind of the rest of the nausea world. So the ER literature hasn't really panned out as nicely as the oncology literature. So to just be mindful of that. We sometimes get asked to take care of patients with other etiologies or teach family medicine or other residents. So just be aware kind of that there's a difference in who you're treating and what you pick. Sorry, the biggest side effect that we come across is constipation. and sometimes people get labeled as not tolerating ondansetron because of constipation. In my mind, it's usually undertreated, just like with opioids, right? So you're the expert in treating constipation, so please use your tools and like open that door again for people to get good nausea control. Dopamine antagonists, again, is like the new hot thing, not so new, but like a little new. And so again, works in the chemoreceptor trigger zone. So anytime you feel it's some medication or toxin causing the nausea, you're probably it's probably a good idea to use the dopamine antagonists. Olanzapine, compazine, didn't put that here for one reason, but like, so olanzapine and compazine are the first go-tos. Haldol used to be the choice in palliative care. I hope people do studies comparing Haldol and olanzapine, because the data we have doesn't match up very well. And I don't, and my pharmacology is not great, but I don't fully understand why the results are that much better with olanzapine than with Haldol. Haldol is much cheaper, it's shorter acting. It would be nice if it worked, but right now the data supports olanzapine better. The prokinetics are something that outside the US get used much more, but metoclopramide is something that's definitely in the toolbox for breakthrough nausea in patients who are getting cancer treatment. So olanzapine had the Cochrane review, and it actually works for prevention as well as treatment. So check if your patient got it when they had their chemo, because then depending, it might be a first line or not. The result was really, and this is the Cochrane review, right? So not only a single study, but the chances that you don't have nausea or vomiting went from 25% of patients being free of nausea and vomiting to 50%, which is a really astounding result. Then the dosing is not quite clear cut yet, right? So do you give them 5 milligrams a day or 10 milligrams a day? Just like with other medications, if you can afford to start on the lower end, I would do that. Sometimes things are dire and we start on the higher end, but then it's worth trying to cut back and see if they get the same benefit. And it seems to be working, it seems to be more effective for the pathway that does the delayed nausea after chemo rather than the acute one. But all of this, nobody's gonna fault you if you give them olanzapine for the acute nausea, right? So don't get too stuck on that. But also if they say, well, I took it the first day and it didn't help, it might be worth, if they feel terrible for 3-4 days after the chemo, it might be worthwhile saying I really want you to try it the later days too, because that's a different way of helping. Then this is a really interesting study, because as much data as we have for people who have nausea and vomiting associated with chemotherapy, we have much, much less for people who are out of treatment, out of that window where we think it's the chemotherapy. And so this was I think it was labeled a pilot, but I haven't seen the follow-up. And they had 30 patients, which in palliative care is fine, right? So they had to be out at least 2 weeks after any systemic cancer treatment. They got 7 days of 5 milligrams of olanzapine and versus placebo, and the results were almost, it feels too good to be true, but I'm taking it. So baseline nausea was 9 out of 10. Olanzapine went down to 1. Placebo, unsurprisingly, stayed at 9. Vomiting stopped, continued with placebo. Appetite improved notably. And then this is the part that is just really surprising. Fatigue actually improved in the olanzapine group, which, yes, if you're nauseous, you're washed out, but that Zyprexa doesn't make you feel more tired. It's just and sedation also was no difference between olanzapine and placebo. So it looks really promising. Yeah, exactly. So once that the comment was fixes everything, and that always makes me very suspicious. So I'm waiting for the next shoe to drop. So again, about 40% of people with moderately to highly emetogenic chemotherapy will have breakthrough nausea despite like, guideline treatment prevention. So as you see these patients, step back and think, because other things are still going on. They still get constipated. They still, have inflammatory processes. They still have a lot of other things going on. So, treat those, just like all of you said in the chat really nicely, like treat those things. If they didn't get olanzapine yet, the new recommendation is that they get olanzapine afterwards. Granisetron is nice because it's like longer acting than ondansetron. And then metoclopramide, it's on the list. It seems to take higher doses to be effective. So, this is one of the ones where you don't start low, exception. And then we get into these later line treatments where you kind of, add things, crossing your fingers a little bit, and benzodiazepine is on this list too. And again, I'll get to those. And now I'm kind of getting into the B list, and as much as it pains me that Haldol is there, I hope this is just, we don't have enough evidence, right? So I hope this changes again, and I hope there's an update on more studies soon, because it's just surprising. But overall, keep it in your toolbox, and definitely if you start someone on Haldol, make sure they're not on olanzapine already. And if they can't tolerate that for whatever reason, and then also have a plan to stop it again if it doesn't work, and be really honest in assessing that. Steroids are like part of like pre-medication for chemotherapy. So if you have someone who has nausea and vomiting in advanced cancer, not related to treatment, so it's not after the surgery, it's not after radiation, it's not after chemotherapy, there's not a lot of data supporting steroids. And that is also something when you talk to people working in our field, we all have stories of someone who has cancer, who's off treatment, who feels terrible and nauseous and it's awful, and then you give them steroids and they feel better. So yes, and I love this concept of enhancing the central antiemetic tone. There's a lot of theories around that, and this is also only a hypothesis. I think it's really more the last thing I put in there. It's like, I think overall people feel better, have a more bandwidth to deal with stuff, and then also the nausea becomes less important. That's how I rationalize still trying steroids when I feel really stuck and everything isn't working. But don't make it your go-to medication for a lot of reasons, but including it hasn't been shown to help in these patients who don't have directly treatment-related nausea and vomiting. Benzodiazepines. So you'll notice the icon I put there. So it's an astounding amount of people's medication list labeled as PRN, nausea and vomiting. And it's especially knowing what we know about the interaction it has with opioids and gabapentin to increase like overdose risk, and the amount of cancer patients who also get opioids. This is not a safe practice. And it can be, there's really that one corner of nausea that it can be really helpful with, and that's the one where people learn to be nauseous and have anticipatory or kind of almost like reflexive nausea. The story is always that someone meets their oncologist at the airport and gets ragingly nauseous, or people who drive up to the cancer center and the nausea starts, even if they just have a lab draw, right? So that's the time benzodiazepines help. You will see patients, or I hope maybe your systems are different, but I have patients in clinic all the time who get sent home with, compazine, Zofran, and lorazepam, PRN nausea, and then end up randomly picking lorazepam as their go-to. And I'm like, no. Let's just rearrange that. And, educate patients, listen to their story. If they have to learn nausea, then make sure they take it safely and appropriately. But otherwise, this is a great opportunity to deprescribe. I do have to say, I don't know, my understanding, Sky, you're pediatric.
Can you hear me?
Yes.
Yes. So I'm pediatric, and we rarely use olanzapine in our pediatric population. And we typically do like Zofran, scopolamine, and Ativan as our kind of go-to with regards to our cancer patients. So I'm not sure if the literature is different between peds and adults using Ativan for chemotherapy-related nausea, but do you have any insight on that?
I don't have on Ativan. And I know that recently they had a review on olanzapine, and it seems, I think the word might have been worthwhile. It was not very committal, but it seems to be worth putting in your toolbox for pediatric patients too. We have a pediatric fellow here who's.
Yeah. It's also used more and more for delirium in the ICU setting.
Yeah.
That's my experience with olanzapine. I don't know about nausea.
Yeah. So good that we have a whole year ahead. And then cannabis products is another one that's there's been a lot of hope around it. And so the expert consensus is right now that it's not recommended other than as a third and fourth line treatment. The studies that have been promising are old enough to predate the serotonin antagonist. So when we didn't really have good tools to treat it. So if you kind of rattle through all the good tools we have now and people still have nausea, it's fine to use a cannabis product if you have access to it, and you can use dronabinol, right? So it should be available like in all states, or medical cannabis where it's available, or recreational. But it's not something I am very transparent with patients that my hopes are not too high. And again, to encourage them to give it a fair shot and then also let it go if it doesn't work. It does seem to be better than placebo, but yeah, not sure what to make with that statement. And then again, like, keep all your tools in your mind. Non-pharmacological treatments can be really helpful. And aromatherapy is, so I put both titles in the same row, which I think I'm going to stop doing. But aromatherapy, the big one is peppermint oil. It seems to be helpful. There's this really interesting work around isopropyl alcohol. And I love the description of olfactory distraction, because anybody who smelled it, that's not aromatherapy, right? Like, so, but so those little alcohol wipes they use for lab draws. And this is an ED study. So where they had patients who were nauseous, but not bad enough, so they didn't need IV fluids. And they used that compared to Zofran. And those patients did at least as good as with Zofran. And to just, hold it a couple of inches in front of your nose and take a whiff. Again, the data for Zofran in the ED is not great. But this is so much more accessible, right? You can send that home with people. And like personal experience, make sure people don't get hydroxyperoxide vibes, because that's not going to work. But this is something you will see patients who have some nausea. It's not awful. They have enough other things going on that you really would love them to not have to deal with that on top of everything. And either they didn't respond well to medications, or often they say, I just don't want to take another pill. Then these are a nice thing to try. And it's been mixed for me in my cancer population. I think let them know and they can try it out, and some of them will get a benefit. Acupuncture and ginger, there's some data behind it. A lot of that is from other situations like post-operative nausea or pregnancy. But again, let people know. And then the bottom three are the ones that your patients have more control over, right? So, and a lot of times when you talk to people, they've actually figured out what distracts them, and they just don't mention that because they don't think it's, a medication and relevant, but those are really great tools. One of our social workers can do clinical hypnosis, which can be helpful, especially people who have these really long chemotherapy plans and get nauseous with the agent that's being used, to kind of help them help themselves in a very sustainable way. Relaxation techniques, and then exercise, obviously not as it's happening, but kind of to increase their bandwidth. And it seems to, like, a well-designed exercise program, which cancer rehab can help with, seems to decrease the severity of nausea that people experience, but that is also like a world that's evolving. And so how, nausea has a really high prevalence, so you'll see it a lot. There's two discussions happening, and one is, do you base it on etiology? So when you think back, do you, like in that graph with the chemoreceptor trigger zone and the vomiting center, do you figure out where is it happening and specifically target those receptors, or do you just have your go-to antiemetic like hit list and go top to bottom? Research, there's one famous study that like had a preference for the empiric approach. You know, I think overall we need both, right? So you need to know which medications have good data behind them and which are known to be effective, and you also need to have a good sense of what's causing this patient's nausea. Again, you'll have a hard time drawing very clear lines, right? Because it's usually multifactorial. The receptors are in multiple locations. Your medications probably hit more than one receptor. So you're not going to like make this a clean cut thing anyway. But I want people to really think it through, what am I treating and what's going on, and also be aware of which medications have a good chance of helping in general, right? So I think it's kind of both. Single agent versus combination therapy. So I have to say, my instinct is, if I have multiple receptors that I can target, I should better take good use of that. And there is also a study that like prefers single agent therapy, which, you know, let's wait and see what happens. I think, you know, absolutely start with one medication, because then if it helps, you save your patients further medications. If that helps to some extent, but not enough, I think the wise thing is to add something from one of the different pathways. And that's also, you know, in broad experience has been really helpful. And essentially that's what we do with chemotherapy induced nausea and vomiting, right? So the pre-medication is a combination therapy as of itself. So like keep your door open, and again, make sure not to double up in the same kind of receptor area as you treat nausea. And then I'm just realizing I'm over time a little bit, that set them up for success. So treat things that don't help with nausea, like dry mouth. Reflux can be exceptionally nausea inducing and often gets overlooked. Constipation, if you can decrease the amount of pills, if you can get them like fresh air and like pay attention to their surroundings, that's going to set up your patients to, you know, be like already a little bit ahead of the curve as they address their nausea. And that's it from my side. What questions do you all have?
I'm not sure if my camera's turning on, but thank you so much for this lecture.
Of course.
That's great. I'm just so glad that you were able to come and talk about this topic with such an evidence-based approach. So for, yeah, we have children. Some folks are asking about the lecture recording. I will send them out to all the attendees at the end of the series. So probably early August, I'll get those out to everyone, because I have to go to them on YouTube and things like that. Hope you'll join us next week. We have 4 really good lectures coming up, and enjoy the rest of your day. I'm on daddy duty, so I'll be seeing all of you all soon. Thanks again.
Thank you.